Very good afternoon to all of you. First of all, I would like to thank the organizing committee for giving me this opportunity to be here and give an ID doctor's perspective on infections in pancreatitis. So a couple of the things of my first few slides have already been elucidated by the previous speakers. I'm not really going to spend a lot of time on this. This just shows the classification of acute pancreatitis, necrotizing pancreatitis being the subset that we're worried about, and a certain proportion of them go on to develop infected necrosis, and we heard that infected necrosis significantly increases the mortality to about 15 to 25%. So if we look at the timeline of infections, we see a bimodal peak in terms of the mortality. And in the first couple of weeks, there is a peak of mortality that's mainly driven by the systemic inflammatory response syndrome. And this is due to a lot of pro-inflammatory cytokine release. Then there's a sort of dip, and after the second week, there's another peak that is seen. And this is usually driven by what is called as compensated anti-inflammatory response syndrome, whereby there's a sort of apparent immune suppression. This is the point in time where infection sets in, and there's a peak also that can happen that leads to death. So if you ask when does infection set in, it's probably by the second and third week of after acute pancreatitis that infection sets in. So just before we go on, I know this is a little bit of a controversial topic, but what is the role of prophylactic antibiotics in acute pancreatitis? So truly, prophylaxis means giving antibiotics when an infection hasn't set in. And though initial studies had actually shown that there was some benefit in giving prophylactic antibiotics, currently there is no recommendation for the use of prophylactic antibiotics in pancreatitis. One, because there's no clear benefit, and secondly, because of the increased risk of resistant infections. And I'll talk more about this a little later in the talk, and what is the current situation in India and what are the kind of organisms we see. There is also an increased risk of fungal infections when you use a lot of antibiotics. So it's like collateral damage. So that is going to happen as well if you use antibiotics. I do agree that sometimes it's very difficult to differentiate between inflammation, sterile inflammation, whether there's an infection or not. And many of our patients come to us already on multiple antibiotics. So it is not just black and white all the time. There's a lot of gray, and it might be difficult. But truly, prophylaxis is not recommended. Antibiotics are only recommended once there's an established infection or for extra pancreatic infections, predominantly in the lung, urinary tract, or for bacteremias. So we know that infected necrosis is probably one of the leading causes for morbidity and mortality. About a third of patients with pancreatic necrosis will go on to develop infections. And most of the recent studies have shown that the greater the amount of necrosis, the greater the risk for infection. And most of this infection sets in after about 10 days. And the majority of organisms are seen from the gut. So this has already been discussed. I'm not going to go into this. We know that there is a lot of inflammation, leakage of the gut, increased permeability, and gut translocation. That is what really drives the infection in pancreatitis. So how do we come to a diagnosis? And I know this is not an easy area where there's a clear test that tells us what is going to tell us a diagnosis of infected necrosis. Obviously, if there is clinical deterioration in a patient who has otherwise been well, new onset fevers, sepsis physiology, or any other clinical signs of infection that has to be suspected. Imaging, I put up a picture of a CT scan where there's gas in the infected pancreatic necrosis. So presence of gas indicates infection, but this may not be there all the time. There are newer modalities like DWMRIs and dual energy CTs, which have some benefit in telling us the difference between infected necrosis and necrosis. So these may be some tools that we can use. Other non-specific markers like worsening leukocytosis, procalcitonin, and other such markers could give us a clue that this is infection and not just inflammation. And positive blood cultures, obviously, with typical organisms with no other focus, would also help to make a diagnosis of infected necrosis. I know there has been a lot of negative information about doing an aspiration and proving the diagnosis and proving an organism. But I'll come to my take on that a little later because of the scenario that we currently see. So what are the common agents that we come across? These are all gut-derived organisms. So Klebsiella, E. coli, Acinetobacter, Pseudomonas, Enterobacter. These are predominant gram-negatives. Depending on where you are, which institute you are, this might change, this rank order might change, but these are the top gram-negative organisms. Among the gram-positives is mainly Enterococcus, and it's mainly Enterococcus faecium. This is important because of its resistance pattern. Most of it is resistant to ampicillin, and almost 2/3 is resistant to vancomycin as well. Staph aureus rarely, and sometimes Streptococcus. And obviously, because of the rampant antibiotic use, there has been some shift in the etiology of these infected necrosis. We're seeing more and more Candida species. It's mostly Candida albicans, but India is the hotbed of Candida auris, and God forbid we start seeing patients who have Candida auris and infected pancreatic necrosis. That's going to be a disaster. There has been description of aspergillus and mucormycosis as well as fungi causing infected pancreatic necrosis, but I think that's quite rare, and I haven't come across any of such cases. So when we think of antibiotic agents that we would give for infected pancreatic necrosis, we would want to choose ideally an agent that is well tolerated and gets good concentration into the pancreatic tissues. So if you look at any sort of older guidelines or the current Western guidelines, they would recommend fluoroquinolones like ciprofloxacin, piperacillin tazobactam, metronidazole because of its very good anaerobic coverage, or carbapenems. Carbapenems are an ideal agent, can be used as a single agent, very good gram-negative and gram-positive coverage as well as anaerobic coverage. Cephalosporins, theoretically, they don't get into the pancreatic tissue as well, so you'll have to use them in high dose and have to give it as an extended infusion, but that also is recommended. So common agents that are recommended is piperacillin tazobactam, either meropenem or imipenem, in high dose cefepime, which is a 4th generation cephalosporin, plus metronidazole. But that is not the situation that we see on a day-to-day basis. We are in a situation where we are dealing with a lot of dangerous organisms and very few drugs that would actually work against these. So ESBLs, or extended spectrum beta-lactamases producers, have become common practice. More than 80% of isolates in India and in our institution are ESBL positive. We now see carbapenem-resistant Klebsiella, carbapenem-resistant E. coli, and Acinetobacter. These numbers that I put up there, that might vary slightly depending on where you are. In larger metropolitan cities, these rates may be higher than what we are seeing. So it varies whether it's from the community, whether it's in the ICU, but extremely high rates of these resistant organisms. We have vancomycin-resistant Enterococcus faecium, multi-drug resistant Pseudomonas, and resistant Candida species like Candida auris that I told you. So it's very, very rare that we actually encounter an organism that is actually antibiotic susceptible. So we know that these kind of resistant gram-negative organisms have a high morbidity, very few treatment options. The drugs that are usually available are very toxic, and it's also resistant to other antibiotic classes as well. And especially in infected pancreatic necrosis, it has been shown that infection with a multi-drug resistant organism has a higher mortality independent of all other factors. So I'm not going to go into a lot into this. This is just telling us that just for carbapenemase producers, there are three types. One is an NDM producer that is predominantly seen in India, an OXA48 and a KPC. Why I'm telling you this, what you might think is unnecessary information is that what we see in India is very different from what is in the West. In the West, if there's a carbapenemase resistant organism, it's most likely due to KPC enzyme, whereas it is different in India. We see mainly the New Delhi beta metallactamase that we see here. And drugs that are produced and are available in the Western literature actually will not work because they don't inactivate the enzyme NDM. So it's important for us to understand that the problems that we have to find solutions for it. The various drug combinations that are available in the West are actually not going to work in our setting. So what are the various agents that we have that would work in this setting? And I would like to call polymyxin our workhorse because it is a drug that we commonly use. It is effective against most of the gram-negatives, including E. coli, Klebsiella, Acinetobacter, and Pseudomonas. So if we want to start a broad-spectrum agent, this is it. Actually, it's a very old antibiotic. It was used in the 1940s and 50s. It got shelved because at that time it was found to be very toxic, significant nephrotoxicity and neurotoxicity. It also has very poor tissue penetration, so it means that getting into the pancreas is going to be a problem, and it also lacks anaerobic coverage. So you'll see that the drug we go to most often is not at all an ideal drug. What is polymyxin? What is colistin? Can we use it interchangeably? Polymyxin B is polymyxin B, and colistin is polymyxin E. Both are very similar, but we tend to use polymyxin for two reasons. One, because polymyxin B is an active drug, whereas colistin is a pro-drug, and it gets converted to the active form in the body. Secondly, polymyxin B is believed to be less nephrotoxic. So wherever possible, unless there's a urinary source of infection, we prefer the use of polymyxin. So what are some of the other agents? And this is, these drugs are quite recently into the market, where we combine a beta-lactam with a beta-lactam inhibitor. And the one that is commonly used nowadays is a combination of ceftazidime, avibactam. Avibactam does inhibit MBL, so it is useful and allows ceftazidime to act on the bacteria. We might need to use aztreonam as well, depending on what sort of molecular resistance pattern we see. So if there's only OXA48 or KPCs, we can use ceftazidime, avibactam, but if we find NDM as well, we need to combine these two together. Aztreonam, avibactam is very similar to the combination above and is now available, so you don't have to give all three. And these are particularly good if you're dealing with Klebsiella or E. coli. They do not work in the Indian setting for Pseudomonas, and they definitely do not work for Acinetobacter. So if it's Klebsiella or E. coli, you're okay to give this combination. So multiple studies have shown that the outcomes in patients who receive ceftazidime, avibactam, and aztreonam, the outcomes are far better with less toxicity compared to polymyxin. So if we have identified an organism, definitely we should switch to this combination, which is less toxic and better clinical outcomes. Other drugs that we could combine for combination therapy includes tigecycline, which is a newer tetracycline, minocycline, cotrimoxazole, fosfomycin, sulbactam, especially combine it for Acinetobacter infections, and aminoglycosides if you're treating urinary tract infections. So really, looking at this list, we don't really have a lot of good choices. So I don't know how well this projects. What it shows is if you have Enterobacteriaceae, either Klebsiella or E. coli, your choice is either polymyxin or ceftazidime, avibactam, plus or minus aztreonam. If it's mainly Acinetobacter and Pseudomonas, your only choice still is probably only polymyxin. So what about gram-positive organisms? Mainly two organisms that we worry about is MRSA, which is Staph aureus, and Enterococcus. It's usually Enterococcus faecium more than Enterococcus faecalis. This is important because Enterococcus faecium is usually ampicillin resistant, and about vancomycin resistance is also quite commonly seen in these in Enterococcus faecium. So vancomycin and teicoplanin are the agents used. If there is vancomycin resistance in the Enterococcus, we would consider the use of linezolid and daptomycin. So what is the role of antifungals? So I told you most common species that is seen is Candida. Rarely there's been Aspergillus and mucormycosis described, but I think that's just for completion's sake. It's not very common to see these. If there are additional risk factors for candidemia, like the patient is in ICU, has been on prolonged antibiotics, lot of long lines, central venous catheters, is on TPN, shows colonization with Candida. So these are certain risk factors for developing candidemia and candidal infection. So if these additional risk factors are there, then we must consider whether we want to give antifungals as well. Definitely no role for prophylactic antifungals, and the main focus is actually on treating established infections. In the timeline, candidal infections come much later than your infected pancreatic necrosis because of bacteria. So what antifungals would we use? Anybody who's critically ill in the ICU the recommendation is to use an echinocandin, either caspofungin or micafungin or anidulafungin. This is the recommended drug of choice, especially if there is associated candidemia. Azoles are good and they get into the pancreatic tissue very well, but they should be reserved as step-down therapy rather than upfront therapy. Amphotericin B, also very good, but it is limited by its nephrotoxicity, and you might have to use combination of these in the situation of multi-drug resistant candida. So this is just summarizing what you would do for empirical therapy in mild to moderate disease, either a carbapenem, polymyxin plus metronidazole, polymyxin plus tigecycline, and consider adding a gram-positive cover if the patient is serious. So severe disease is similar to the above, but you will add a gram-positive cover and may also consider adding antifungals. So once you have an established etiology, you treat according to that, give as minimum antibiotics as possible, give drugs which penetrate into the pancreatic tissue best, and consider combination therapy. In this current scenario, we really don't have any oral antibiotic agents that we can use. So I'm not going to talk about drainage procedures, but as an ID physician, whenever I see a collection, I think it should be drained. So I think in this situation, yes, we may want to delay drainage, but additionally, what is going to help us is that if we identify the pathogen, we can really titrate the kind of antibiotics we give, because none of these are cheap. They all have their own toxicities, and you're going to be giving this for 2 to 4 weeks. So if you have an etiology on hand, it is going to simplify things much further. So is there any hope? Do we have any hope with regard to antibiotics? So I just want to tell you about this drug, which is a combination of cefepime, zidibactam. Really just look at that first column in green. These are the MICs for all gram-negative organisms, and this is in the pipeline for phase 2 studies have been done. So this is something that really might be a game changer in terms of treating gram-negative infections. So it covers all the gram-negatives that are there, Pseudomonas, Acinetobacter, Klebsiella, and E. coli. I've recently done a phase 2 study in CMC. It's shown to be really good. So really look forward to this coming out in the next few months, which will really be a game changer and maybe help us to move away from polymyxin, which is a very toxic drug. So I'd just like to conclude by saying that this is a very difficult clinical scenario that we come across. And unless we identify infections early, there's going to be a lot of mortality. We're seeing a lot of drug-resistant pathogens. These drug-resistant pathogens have very, very few treatment options. And if possible, achieve source control. And despite our best efforts, mortality still remains high. And we really need a multidisciplinary approach to improve outcomes and reduce mortality. So I will stop here. And thank you for your patient listening.